Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 561 of our pharmacotherapy series, which majors in schizophrenia. The next question reads, once JPJ is started on clozapine, how should she be monitored? What parameters should be checked and how frequently? Clozapine treatment requires weekly absolute neutrophil count checks for at least the first 6 months of treatment. Assuming no problems with her absolute neutrophil count values, that is an absolute neutrophil count equal to or greater than 1,500 per microliter, she can then go to absolute neutrophil count checks every other week for 6 months, and then absolute neutrophil count checks once every 4 weeks thereafter. In addition, her weight should be monitored at least monthly, and perhaps weekly, for the first few months of treatment, along with at least quarterly serum glucose and lipid panel checks. She should also be asked about any problems with orthostasis, dizziness, constipation, sedation, and drooling during any office visits. We will now discuss serum concentration monitoring. Data supporting a strong correlation between antipsychotic serum concentrations and efficacy are lacking. Therefore, routine therapeutic drug monitoring of antipsychotic serum concentration is not recommended in clinical practice. The exception is clozapine, which has sufficient data to support a higher rate of response at levels above 350 nanograms per milliliter. Monitoring of serum levels is appropriate in the following clinical scenarios. 1. Psychiatric decompensation on a previously effective dose. 2. Poor response to medication despite adequate dose and trial duration. 3. Unexpected adverse effects while on a previously tolerated dose. 4. Addition or withdrawal of an interacting medication. 5. Patients with potentially altered PK, e.g., medically compromised, children, and the elderly. And 6. Suspected medication non-adherence. The next question reads, JPJ responds well to clozapine, taking a dose of 450 mg per day, with higher doses causing intolerable adverse effects in JPJ over time. JPJ begins to become depressed as she realizes that her life has not gone the way she thought it would. Her psychiatrist assesses her as having depression secondary to her schizophrenia, and the decision is made to start her on paroxetine 20 mg daily. Is the addition of paroxetine appropriate for JPJ? Although paroxetine is an appropriate treatment for depression, it is most likely not a good choice for JPJ, there are data that show that paroxetine can cause anticholinergic adverse effects in patients, which could overlap any anticholinergic effects caused by clozapine. JPJ would need to be monitored for increased anticholinergic adverse effects, and possibly be treated for them, e.g., bowel regimen for constipation. Selection of an antidepressant with a lower risk of drug interactions, such as escitalopram or sertraline, would be more appropriate. Several months later, the clinic receives word from JPJ's primary care provider that JPJ is pregnant, as confirmed by blood test. JPJ is still receiving clozapine and is fairly stable psychiatrically on the medication, even working part-time in a supermarket. JPJ does not want to lose the baby, but is worried about the effect of being on medication despite knowing it is what is keeping her stable. Should JPJ be continued on clozapine, and what are the risks to her baby if she does or does not? Treatment of schizophrenia with antipsychotics during pregnancy must be considered carefully. As JPJ is currently stable and functional while taking clozapine, there is a significant risk of relapse if she stops the medication. During this relapse, if she were to engage in high-risk behaviors, it could be quite dangerous to both her and her baby. Maintaining stability is of great importance, as if JPJ can take care of herself appropriately, it is more likely she will also take care of her fetus simultaneously. However, antipsychotics do carry risks of teratogenicity, and JPJ should be counseled on these risks. Clozapine is rated as pregnancy category B by the US FDA, which is better than most antipsychotics but still with some risk involved. The decision to maintain JPJ on clozapine during her pregnancy should be made by her psychiatrist, obstetrician, and other care providers to determine whether continuation of clozapine, and presumptive stability of her illness, is appropriate. JPJ gives birth to a son, PRJ, who has a normal delivery. Over the course of time, PRJ's pediatrician notes he is not socializing like other children, especially into adolescence. He is now age 15 and tends to isolate himself, does not have many peer friends, and recently has started performing poorly in school. His teachers have asked the pediatrician to evaluate PRJ for potential attention deficit hyperactivity disorder as he is often found not paying attention in class. JPJ also tells the pediatrician that she thinks PRJ still has imaginary friends, as she often sees him alone in his room talking to people who are not there. What is potentially happening with PRJ and how should he be treated at this time? PRJ is at higher risk for and potentially showing symptoms of early-onset schizophrenia. His lack of socialization and his isolation could be symptoms of the prodromal phase of schizophrenia. His imaginary friends could be PRJ responding to auditory and/or visual hallucinations. Imaginary friends are not usually seen into adolescence. If these are hallucinations, this could also explain his lack of attention in school, which would not be attention deficit hyperactivity disorder. Considering his mother has schizophrenia, there is a definite genetic link to the illness in PRJ. Once PRJ is evaluated for schizophrenia, it may be appropriate to initiate an antipsychotic at that time. If so, he should be started on an agent with minimal adverse effect burden at a minimal dose to control his symptoms. He should be evaluated regularly for possible medication discontinuation if warranted, but may require more long-term treatment depending upon his response and prognosis. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom, and if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 562.